Hi, and welcome to MedInsights Unleashed podcast. I'm John Collins, and I hope you enjoyed this new episode, and thank you for listening. Well, good morning, everyone from MedInsights Unleashed. We're going to take a fresh look at the most debated areas in hepatocellular carcinoma, the evolving role of TACE in the intermediate stage. New data is emerging from studies such as the replacement study, LEAP-12 and EMERALD-1, and we will go into these in more depth during our discussion. And we are pleased to welcome back Professor Markus Peck to help us navigate this rapidly changing landscape. Professor Peck is the Professor of Medicine and Chairman of the Department of Internal Medicine and Gastroenterology at Klinikum Klagenfurt in Austria. So, Markus, would you like to introduce yourself?
Yes, John, thank you very much for the introduction. So I'm an internist specialist in gastroenterology and especially hepatology. The research that I've been conducted was into several aspects of chronic liver disease. It started with portal hypertension and complications of portal hypertension. It also involved viral hepatitis and co-infection. And then since over 20 years, I've been focusing on liver cancer management, especially drug treatment of HCC, but also early on already the role of TACE and also on predicting which patients would be good candidates for TACE and which patients would not be good candidates for TACE. So this is an area where actually many things have happened, and we came from the times before there was any drug treatment available for patients that were non-surgical candidates. And in those patients, TACE was the only thing that was really available. And so we were TACing just all the patients that we could get our hands on with sometimes quite dismal outcome. So therefore, this has been a focus of my research and also my educational activities for quite some time.
And you just recently published an editorial in Liver International discussing an area that we've currently used as BCLC algorithm in the intermediate stage for hepatocellular carcinoma. BCLC has been the foundation for multiple years for assessing patients and the disease. What's changed to make you feel that BCLC is now not as relevant as it was before?
I think I didn't really say exactly that in my editorial. BCLC is a fantastic system, and BCLC is also an evolving system, like many systems that we're having, because we're gaining new knowledge, but at the same time, we're also adding new therapies, and therefore, our staging becomes, it changes over time. So BCLC, I think, always was and still is an excellent system to understand the basic principles of the management of hepatocellular carcinoma. But also, already shortly after BCLC came out, and I think it was first published in 1999, it became clear that you have on one side the curative treatment options with resection and transplant that were actually fairly well characterized. And then you had the advanced stage, for which at that time you did not have any therapy, but you had the advanced stage. And that was defined by not having a therapy for that stage. And then you had the intermediate stage where TACE was the standard of care, but it was always clear that the intermediate stage was an extremely heterogeneous population of patients with very different tumor characteristics, disease characteristics, and also outcomes. And therefore, it's not surprising that in intermediate stage, things are becoming now a little bit more granular. And the first ones who were actually pushing the limits here were some American surgeons, who questioned the Milan criteria for transplant. Francis Yao and colleagues, by developing the San Francisco criteria and saying Milan is too strict. So there are patients that are intermediate stage patients, but good intermediate stage patients, which we can actually transplant. Yeah. And along those lines, other classifications like up to 7 criteria and so on were developed to say, okay, there's very good intermediate stage patients that are actually candidates for curative treatment. And if they are treated curatively, their outcome is much superior to giving them the standard of care.
Can you explain up to 7 criteria for the listeners?
Oh, up to 7 criteria says that, in the Milan criteria, it was that for transplant, patients should only have not more than 3 nodules, not larger than 3 centimeters, or 1 nodule not larger than 5 centimeters in diameter, and of course, no vascular invasion and no extrahepatic spread. And that those criteria are very good because the outcome, if you stick to those criteria of transplant, is very good. However, people understood that you're actually denying transplant to a number of patients that would also benefit from transplant, but are not candidates because they're outside Milan. So a large retrospective analysis was conducted that looked at, I think, over 1,400 transplant patients retrospectively. And they found that if you have the diameter of your largest tumor nodule plus the sum of the numbers of tumor nodules, if that does not exceed 7, your patients will be fine, will have a good risk for transplant. So that means, for example, if you have 1 nodule, it can be 6 centimeters in diameter. The sum is 7, so it's within the up to 7 criteria. Yeah. So while in Milan, it could maximum be 5 centimeters. Here, it could be 6 centimeters. So it was less restrictive. Yeah. And if you have 2 tumor nodules, then your largest nodule must not be larger than 5 centimeters. Yeah. So, but in Milan, if it's 2 nodules, it shouldn't be larger than 3 centimeters. So you could transplant more people, and you were actually taking some of the better intermediate stage HCC patients and transplanting them with good outcomes.
Is that curative intent then?
It's curative intent, yes.
Yes. Yeah. So just for the listeners, I just want to make
Yeah.
sure. Does neoadjuvant therapy now play into this? I know that we're talking about intermediate, but I just thought I'd ask the question.
So neoadjuvant treatment in the intermediate stage, you would actually call downstaging, right? Or some call it conversion. Yeah. So no matter which terminology you're using, this has been actually shown quite nicely that if you have a tumor that is outside any of the established transplant criteria, but you're able to convert or downstage the patient and his tumor into a curatively treatable stage, and then you treat the patients, for example, by transplant, the outcome will be good enough to allow transplantation. Recurrence rates are a bit higher than if they're within Milan from the start, but they're still acceptable.
That's great.
And since the survival between a curatively treated patient and the patient treated with a palliative treatment option, for example, TACE, is so large, yeah, I think it is warranted that you actually try to give these patients these adjuvant treatments, because this could be either local ablation, it could be an intraarterial treatment modality like TACE or TARE, radioembolization. And as we know now, or we are accumulating data, it could also be drug treatment, because with the IO-based therapies, we're not only getting a lot of stable disease, but we're actually getting some objective responses in 20 to 36% of patients. And so some of the patients with larger tumors can be converted to a treatable stage.
That's a great transition to my next question from your editorial. You do talk about IO therapy combinations here, especially the replacement study with the Tiso-Bev in the intermediate patients. How has this study become so important? Because it's not a randomized study, it's a single arm study, and your thoughts on the replacement study before we talk about the other randomized phase 3 studies that are coming up.
So actually, I think we should go one step back, because there was a predecessor of the replacement trial, and that was a study not using IO-based therapies, but using a TKI, lenvatinib, in patients with intermediate stage HCC, but large intermediate stage HCC tumors, patients whose tumors were outside the up to 7 criteria. And this was a retrospective analysis from Japan. And Japan has a huge database, so they could actually identify a number of patients that were treated with drug treatment in intermediate stage HCC outside the up to 7 criteria, despite the fact that usually the treatment of choice would actually be TACE for those patients. And then they did propensity score matching, a 2-to-1 matching with patients in the same tumor stage that received TACE, and found that the survival of these patients, not the response, but the survival, was much superior in the drug-treated patient group compared to the TACE group, even though those patients were intermediate stage HCC patients and by BCLC algorithms should have received TACE. Yeah, so it became clear that on the other side of the intermediate stage, the patients that are rather advanced, treating them with TACE is probably not a very good option. And this was my observation in the earlier days, because we would TACE all those patients with unfavorable outcome. Yeah. So here they could show that actually treating them with drug treatment, even though they're intermediate stage, the outcome was much improved. And the replacement trial was the follow-up trial study to that, where they took these patients that were intermediate stage but outside the up to 7 criteria, so larger intermediate stage patients, and treated them with atezo-bev IO anti-angiogenic combination therapy, and again showing that the survival of these patients was very close to the survival that you could achieve with lenvatinib as drug treatment, and definitely better than the control group that was treated with TACE in other studies. So this gives us the strong feeling that in more advanced intermediate stage patients, it's the drug treatment that does the job. And TACE is to some extent dangerous for those patients, because you're cutting their arterial blood supply, and therefore there's the danger of inducing liver failure in those patients.
You talked about atezo-bev, you've talked about lenvatinib. When we launched lenvatinib, Julie and I brought out Response Matters, right? So does that change in your current thinking of what you are talking about now? Response from a combination therapy versus response that you get from TACE and the sustainability of overall survival?
So I think this question is not entirely easy to answer, because it's not so surprising that you get a better response if you combine two treatments that you would ordinarily use sequentially. But what you have to look at is not to compare combination therapy versus monotherapy with TACE, because you will get a better response with the combination therapy, but you also already lose the next line of treatment. So here you would have to look at combination therapy, TACE plus IO, for example, versus sequential therapy of TACE plus IO followed by after TACE, And then the question is, what's the progression-free survival of these combinations? And we don't know that. So it is not surprising to see a trial where TACE plus IO combination, for example, durvalumab, bevacizumab, let's use this combination because this is what's being used in Emerald 1, shows a longer PFS compared to TACE alone. But what happens in the TACE alone arm is that most researchers would add or give atezo-bev after progression in the TACE arm. And then the question is, what is the time to progression after you give atezo-bev? And this is the reason why these trials, neither Emerald 1 nor LEAP-012, nor TACE, which actually showed the OS data being absolutely non-significant despite a significantly longer PFS with the combination arm, will not give you an OS benefit. And if you look at it from a patient perspective, and you ask him, what's important for you? Is it important for you to have a long PFS with the combination, or don't you care whether you receive it sequentially? And isn't the one thing that really matters to you your overall survival? The simple answer the patient will give to you is that, of course, what I really care about is for longer live, doctor. Yeah. So this is why we have to look at that. And then when you combine two treatment modalities, you always add toxicity.
Yes, I saw that in the results.
Yeah. So when you use it sequentially, you don't get that. You get toxicity from one thing, and then you get it from the other thing, but you don't get it at the same time. So that is the reason why I am not so totally enthusiastic about combination therapy till we show that it actually improves survival.
Do you think with the current treatments, and we've talked about neoadjuvant, the criteria now are changing to allow more patients coming in? We've talked about monotherapy and combo, and there's more lines of therapy now. Is it harder to show overall survival benefit?
Yes, from a trial perspective, it's more difficult. But from a patient perspective, it doesn't matter. The patient wants to live long. Yeah. So if he gets it with several lines of treatment, fine. Yeah. He'll be happy. Yeah. He wants to live long. He does not want to have a lot of toxicity during his course. Yeah. So I think this is what really matters. Yeah. So from a trial perspective, it's more difficult, but our patients live much longer. So this is actually great.
With the TACE and LEAP-12 data, are you positioning certain patients that would be suitable for the combinations versus those patients that may not be suitable, where you want to get a more rapid reduction in tumor size versus the sequential therapy that you're talking about? Which patient would fit into that category now on the thought process that you have combination versus sequential?
So the combination, in my opinion, is not for the more advanced patients. Those you would rather treat with drug treatment. And actually, one trial that we have not mentioned is the ABC HCC trial, which is actually comparing TACE in one arm and atezolizumab in the other arm. And even though the trial is not completed, the interim analysis shows a very strong signal in favor of drug treatment over TACE. Yeah. But in my opinion, in patients where response matters to you the most, those are the patients that you want to convert to curative treatment. In those patients, it could actually play a role because you want the tumor response, you want shrinkage of the tumor, and it's not so important that this shrinkage lasts forever, because you're gonna transplant the patient then anyway. Yeah. But you want to downstage or convert him to a curatively treatable stage. And that, in my opinion, is more feasible with a combination than with monotherapy. Unless your tumor has specific characteristics which will tell you that this patient is a fantastic candidate for TACE, for example.
So what are the characteristics then that you would really seriously look at from a TACE perspective and where it fits into the treatment algorithm now, based on all the range of therapies that you have?
So basically, TACE is good if you have excellent liver function. This, I think, is a prerequisite. And a tumor with a very well-defined tumor margins, ideally with a capsule and a single feeder artery, because you have an ideal target for your embolization. And then it's very likely that you will achieve a complete response, even with TACE. So if you have these radiologic features, I think then TACE is still a viable option for this patient. And of course, the tumor should not be amenable to ablation, because ablation, if it's done by somebody who knows what he's doing, is a sure bet. You grill it and it's gone. It's definitely, you don't have this question, does it respond? Does it have additional feeders and so on? You don't have any of these questions, you just burn it. Yeah.
Just burn it, either freeze
yeah.
it or fry it.
Yeah.
We've mentioned several studies now, ABC, LEAP 12, Emerald 1, Duratremi. You've got so many different regimens that we didn't have for 10 years. Where do they fit into the treatment algorithm? Is there different patient types with the combinations?
I think there is, but it's not for the majority of patients, The majority of patients, your average risk patients with not a lot of comorbidities, will be candidates for any of those treatments. And then you will go for the treatment that gives you the best OS data with the least toxicity. And I think this is the reason why many patients end up receiving atezo-bev in first line, because it gives you good OS, but it gives you also not a lot of toxicity. Yeah. So obviously, there are some patients that are no candidates for anti-angiogenic therapy, cardiovascular problems, heart attack, stroke, things like that, prothrombotic conditions, and so on. So those might not be candidates for this kind of treatment, but many patients actually are candidates for this kind of treatment. If you want to avoid the anti-angiogenic therapy, and you have a patient that is not super fit and not really able to tolerate a lot of toxicity, those are ideal candidates probably for durvalumab, because this combination actually gives you fairly good OS data, not much worse than atezo-bev, but it has a good toxicity profile. So it's really quite well tolerated.
So where does monotherapy fit into the whole process?
Monotherapy, you mean with durva or with lenva? With lenva, yeah?
Yeah, lenva.
So lenva actually, if you look at the data, is a very, very good treatment option. But the tolerability is not as good as of the IO combinations, yeah? So if you look at the OS data, it's marginally worse than IO combination therapy. And you could argue actually that OS data looks better than durvalumab, but this has not been formally compared. Yeah. However, the tolerability is not quite as good. Patients do suffer. Some are nausea, they lose weight, they lose appetite, and therefore it's harder to treat a patient with lenvatinib than with a IO combination therapy. But it's still a good treatment option, So the question is whether you use it in first line, unless you have to, because you're having contraindications against other treatments, yeah? Or whether you use it as a second line treatment, yeah? Of course, it has not been tested in this way, because we have no second line data on randomized data on any treatment post IO first line, but it's still a good option, and we actually use it often in that way.
So when a patient's sitting in front of you, what are the questions that patients should be asking you about treatment?
So it's always, it's always the balance between how effective your treatment should be and how toxic it can be, and what they're willing to tolerate. And I think this is very difficult for a patient to evaluate in advance, because if you look at the lists of side effects, I don't think they will tell you a lot how this drug is really tolerated. Yeah. So this is where your physician recommendation comes in, because you know a number of patients with any of these regimens, and you can tell a little bit better what the preference for a given patient might be. However, what you never know is people respond differently to different therapies. So of course, on an individual patient basis, you're unable to predict what will happen in terms of toxicity and efficacy. But in the end, we, as you said previously, we end up giving patients several lines of treatment. Patients will end up receiving many of those treatments anyway. Yeah. And in that case, I think it's not really that important what you start with.
Oh, okay. Because I was going to ask, where does BCLC treatment algorithm move to the future? You did say it's become more flexible. How
Yeah.
is it going to be used as a diagnostic tool moving ahead?
So if you look at advanced stage treatment, where in BCLC drug treatment is the treatment of choice, and rightly it is that, because that's where the studies have been performed. BCLC is not very specific, and nor are any other guidelines that we have. And the reason is that there is no prospective data that would allow you to give a firm recommendation: use this first, use this second, use this third in a given patient. Yeah. The data is not available, and it's likely that the data will never be available. Yeah. So it really depends on your discussion. And actually, the new VCLC treatment algorithm with the so-called Q's AI module actually acknowledges that. It says it's not only your OS data, but it's actually values and treatment goals and patient perspective that you should factor into this decision, discuss it with the patient, and then you come to a joint conclusion about which kind of treatment you want to use.
So how does the multidisciplinary team fit into the overall treatment algorithm of a patient? What happens from your side as a clinician and hepatologist that's treating a patient with liver disease?
So I think the multidisciplinary team is an extremely important place for discussing your treatment decisions, because what we've come to is that we don't follow any specific treatment algorithm like slaves. Is you actually personalize your treatment decisions on many factors that you cannot really put into guidelines or a BCLC treatment algorithm. Yeah, so you'll always have to factor in many aspects, and this is what you discuss in your tumor boards. And therefore you might choose to combine treatments in several ways. What that is not part of any guideline or treatment algorithm. Yeah, but you still might decide to do that. Yeah, and it has been shown, there's data on that if you do that, you will actually improve your patient outcome compared to just giving him one treatment according to the algorithm. Yeah. And this is what's being discussed in the tumor board, plus also, of course, feasibility, because you need your surgeon to tell you what he can do and what he cannot do safely. You need your interventional radiologist to tell you this is a good idea, this is not a good idea in a particular situation. Yeah. So all these, and you need the hepatologist to say, okay, his tumor looks like that, but we also have to consider liver function and other aspects for our treatment decision.
So thank you for that. Can we just discuss research for the future and your thoughts on what are the trials that are going to be most impactful over this year, maybe presented at ASCO versus next year, and where research is going?
Yeah, so last year was actually an interesting year because we were hoping for the next step in terms of data with regards to drug therapy. And we were hoping for the outcome of triple therapy studies to be positive, triple drug therapy, I should say. And unfortunately, it turned out not to be the case. Yeah. So this was important, but at the same time very disappointing for the whole field, because this would have given a huge stimulus to research to be conducted. Yeah. So what we are now waiting for is still trials that have been ongoing for quite some time, but have not finished yet. Yeah. So, for example, there's trials in the adjuvant setting of HCC that we're still waiting to be completed. We have one trial, the IMbrave 050 trial, that in the end was a negative trial. So, unfortunately, and we're waiting for another trial, but I'm not sure, or actually I know that it's not going to be released this ASCO. Yeah. So
okay.
it's still some time to go here. Yeah. And we're also, waiting and interesting to see neoadjuvant trials. Yeah. Neoadjuvant trials would be very interesting in early stage HCC, but also in other stages. So I think this is something that we are really looking forward to. Yeah. Then ABC HCC, which has shown interim data, we are waiting for the final data, and it will still take some time. But I think this is quite an important study.
Can you talk about the ABC trial, because the endpoint is TSF? That's quite unique in itself. Can you explain that trial and what the endpoints are?
Yeah. So the endpoint is failure of treatment strategy, and that is acknowledging something that you mentioned earlier, that you have problems running an OS trial in intermediate stage HCC, where usually patients progress to advanced stage after they progress in intermediate stage. So in the end, you're then looking at the outcome of an advanced stage patient, yeah, even though you treated him in intermediate stage. And that, of course, creates problems. So looking for a meaningful endpoint in intermediate stage is not all that easy. So that's why some studies used PFS, and that, of course, is better than nothing. But the ABC-HCC trial tried a different approach, saying failure of treatment strategy means that we have to go on, switch to the next treatment strategy. And that is differently defined for drug treatment versus TACE. Because in TACE, we say if you TACE a lesion twice and you do not get a response, it's failure of TACE. Meaning that if your tumor doesn't grow, but it doesn't shrink, it stays the same, then your TACE, where you usually would expect shrinkage, or at least necrosis of the tumor, then this is failure. While if you have stable disease with drug treatment, this is still considered a response because the tumor is not growing. So that's the difference in response evaluation in the two arms of the ABC HCC trial. And of course, this can be debated, and it will be debated. And therefore, also in this trial, it will be interesting to see what the ultimate outcome with regards to OS in this study will be, even though it's not a primary endpoint.
I hesitate to say, but is it questioning the actual endpoint of OS?
It's just acknowledging that
way.
it's difficult to show OS differences, and at the same time, it also takes a very long time to show OS differences. Yeah, because if your patient in advanced stage lived 2 years with drug treatment on average, yeah, and the outcome in the replacement trial or in the lenvatinib trial in the Japanese studies of intermediate stage patients outside the up to 7 criteria was 34 months or 37 months, then you're looking at very, very long, many years until you get a result. Because you have long recruitment phases in those trials, 3 years, 4 years, 5 years of recruitment. And then it still needs another 3 years until you get median survival, You have to do something about that in order to learn what you're doing. Still, OS, of course, is the ultimate endpoint, so it will be interesting to observe it. But if you know that, for example, drug treatment is at least as good or better than TACE, but has less toxicity and less dangers, it's good if you know that earlier.
Is treatment failure a better endpoint?
That we will only know once we know the OS, because then it will tell us, is it meaningful or is it not meaningful? We hope that it's meaningful, but you can only evaluate a surrogate parameter if you have the final endpoint, because then you can understand, does the surrogate parameter really work well as a surrogate parameter, or maybe doesn't it work quite well?
The life has changed so much since 2000, right?
Yeah, life has changed so much, but the survival of our patients has become so much better,
Yeah.
And we became so much aware of the fact how important in the liver patient it is to preserve their liver function. Yeah. And we learned that it's more important to preserve liver function than actually killing the tumor at all cost, So this is very important insights, and understandings. And so people become a lot more considerate of preserving liver function.
That goes very, very well with your first podcast with us, which talked about navigating the risk of aggressive treatment.
Yes, yeah.
So I would recommend that. Sorry?
This still holds true.
I was going to say, I would say that for the listeners that they should listen to that, because you give an excellent overview of the questions and theories and the response to treatment versus risk of treatment. You were about to say, sorry?
No. I'm just saying, that's true. Yeah. You can observe this with any kind of treatment. Yeah. Because there have been analyses showing that also for curative treatments like surgery, what is more important, to actually remove all the tumor and risk decompensation, or be not absolutely radical, but actually do not get the liver decompensation. And it turns out that actually tumor recurrence is a much less of a threat to survival than hepatic decompensation.
Markus, thank you. If you had to sum up our talk today in 3 bullets, what would be the 3 bullets that patients should take away from this talk about therapy and staging, treatment, monotherapy versus combination?
So I think one thing is that you should always make sure, or inquire, and maybe inquire 2 or 3 times, whether there is a chance that if you're not in a curative treatment stage, that you are converted into a curatively treated treatment stage. Because there's no doubt about it that if you're able to receive curative treatment, this will offer you the very best survival possible. Yeah. So I think this is becoming more and more clear. And so combination therapies, in order to achieve a curable treatment stage, is something that we're always discussing, and your physician also should always discuss. Then if you're in intermediate stage, but your tumor is large, and maybe not very well circumscribed, or you have multiple nodules, then this is a treatment, and somebody suggesting TACE to you, you should also question that. Yeah. Because simply because in any treatment algorithm, TACE is recommended in this overall stage, it might not be a good idea in a very specific situation. And then I would say, don't be afraid of drug treatment, because drug treatment today offers you a much better response and a much better survival option than it used to with all the treatment options. And if the situation for TACE is good, you have good liver function, very well circumscribed tumor that can be treated, and the interventional radiologist is very, very confident that you can actually get a complete response, then TACE probably is still a good treatment option. But if the tumor is large, it could be that TARE is the better option than TACE. We didn't talk about TARE,
Yes. Can you've mentioned it twice now. Can you talk
Yeah,
about TACE?
there's actually two. So there's different interarterial therapies. One is TACE, which is transarterial chemoembolization. And here, the main principle of action is that the tumor is mostly supplied by arterial blood. And so you occlude the artery, the tumor feeding artery, with a mixture of a chemotherapeutic agent and an agent that blocks the bloodstream. And so the tumor dies through this combined action of hypoxia and chemotherapy. But the main mechanism of action is hypoxia, not the chemotherapy. Yeah. And therefore, since you're blocking arterial blood supply, you have to be very careful that you only block the blood supply to the tumor. And very often, especially if the tumor is large and if you have multiple nodules, you will actually also have collateral damage to your non-tumorous liver. And this is what bears the risk of liver failure. Now, transarterial radioembolization, even though it sounds very similar and is performed in a similar way, also with an intraarterial catheter, uses smaller particles where radio-labeled beads are brought into the tumor, injected into the tumor. And the main mechanism of action is not stopping the arterial blood supply, but the main mechanism of action is actually internal radiotherapy. And so this treatment modality is not so risky with regards to collateral damage, with regards to hypoxia. Yeah. And so it also carries less risk of hepatic decompensation if done by an experienced operator. Yeah. And it has been shown that especially if you have single large tumors, which can usually not be treated very well with TACE, those might still be good targets for radioembolization.
So you've really reinforced that patients with liver disease and cirrhosis, should be treated by specialists and multidisciplinary teams. They should be heading to the multidisciplinary teams to get the appropriate treatment. Well, Markus, I want to thank you on behalf of the MedInsights listeners. This has been a fascinating talk. I want to say thank you for all the research that you are doing in Austria and around the globe to improve patient outcomes. It's amazing, and you've been a long mentor of mine for many, many years, and I want to thank you for that as well.
Thank you very much, John. It's always a pleasure, you know.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.